Good morning. Welcome, everyone, and thank you for joining us this morning for this important discussion. We are here today to talk about the exciting possibilities of creating a comprehensive platform that will host data from governmental, nonprofit, healthcare, and other organizations to help researchers better predict, analyze, and most importantly, address health disparities in the state of Michigan. As we are all well aware, Detroit experiences significant health disparities and inequities that are only getting worse. Conditions such as obesity, heart disease, and hypertension pose incredible challenges to the health of too many Detroiters, and we need innovative strategies to address them. We need to develop more targeted and measurable interventions so we can actually start impacting health outcomes and measuring those outcomes. There is currently an immense amount of data, as we all know, but it exists in isolated vacuums, making it incredibly hard to transform it into something valuable. Today's panel will explore how we could impact the future of healthcare outcomes and find a way to collaborate across sectors to capture and utilize this data in a strategic and unified way. Wayne State University is in the heart of the city of Detroit and belongs to the community that it serves. The university is a natural and neutral convener to ensure that information is made available to those who develop life-improving initiatives. We are committed to building an interactive database, inspiring partnerships necessary to acquire and maintain data, and tapping into the many resources in our community so that we can build powerful and lasting health outcomes together. I'm very happy to be with you today, and I know that this is going to be a very successful panel. Thank you.
Please welcome Director of Health, Veterans, and Community Wellness for Wayne County, David T. Brooks.
Good morning, everybody. Thank you. The hearty souls who come to the 7:45 a.m. session. Those of you who are not my friends and colleagues from the past, I really appreciate you coming. My friends and colleagues, I extra appreciate you coming because you know me. So you know the double challenge it is at 7:45 in the morning with me. And those of you who are just arriving from the Pink Pony, if you put your heads down, just do it quietly at some point, maybe put the napkin down or whatever. So thank you again all for joining us today. We've got a great panel that we'll get to after kind of our preliminary discussion here. And I think you'll find it pretty interesting. We have a good diverse group of panelists coming from different perspectives. So while we traditionally think of it as health care, today's focus is going to be a little bit more on the health portion of it and from a broader viewpoint than just the clinical services. But you'll hear all about that both from our keynote speaker as well as from the panelists. So without further ado, let me introduce our keynote speaker, Dr. Phillip Levy. Dr. Levy is a tenured professor at Wayne State, where he serves as the Assistant Vice President for Translational Services and Clinical Research Innovation, as well as Associate Chair for Research in the Department of Emergency Medicine. He is board certified emergency physician, a fellow in the American College of Emergency Physicians, the American Heart Association, the American College of Cardiology. He is also a standing member of the National Institute of Health's Cancer, Heart, and Sleep Epidemiology Study Session. And since he's such a low achiever, he's on the Grants Advisory Panel for the Blue Cross Blue Shield Association Foundation, as well as the ACEP's Scientific Review Committee, and a number of other things that I won't necessarily review here, but he's a busy guy, obviously. Phil's research interests, as you're going to hear a little bit about today, center on health disparities related to hypertension and hypertensive heart disease, with a dual focus on acute management and population-level cardiovascular disease risk reduction. He's an internationally renowned clinical expert and research expert in cardiovascular disease and has led close to 90 funded studies in clinical trials at Wayne State over the last 15 years. So is very published as well, as academicians like to be. So without further ado, Dr. Levy.
Thanks, David. It's really nice when you write your own panel, your own sort of intro, and then you can say all the wonderful things about you that you want. As we're kind of leading into this, I think it's really important maybe to to sort of set the background. So what David was just describing, all that stuff about me, I don't know if any of you guys saw this or read David Brooks in the New York Times, but he had a great article a few months ago called The Moral Peril of the Meritocracy, which is all about two mountains in life. And the first mountain is how you get your personal achievements and start and do these big things to get you where you think you want to be. And then you get there, all that stuff that David just mentioned, and you realize, what have I done? What am I trying to do? What is life all about? And the second mountain is how do you change the world? How do you leave your mark on something? Or how do you contribute to the greater good? And this talk or in this session and the work we're doing right here is all about the greater good, because with all of those credentials, I could go anywhere I want in the country to practice. And I want to be in Detroit practicing because my second mountain is to reduce heart disease death. And my second mountain is to give every person who lives in the state of Michigan, in particular the city of Detroit, the opportunity to live a long, healthy life. And we're going to talk about how important data are to make that happen. So by way of disclosure, I do a lot of work with the state of Michigan. That wasn't included on my bio sketch. I'll make sure to add that for next time. But we do a lot of work around heart and stroke disease prevention, and I'm going to walk you through why that's important and then hopefully show some really neat, I guess I can say that in this crowd, neat insights into what data can tell us. So some of you may have seen this graphic here, but if you look at Detroit, 48201 is the zip code versus Grosse Pointe, 48236 zip code, just a couple miles away, beautiful drive along the water, but there's a 13-year difference in life expectancy, and that's just not right. Why does a 13-year difference in life expectancy exist within basically the same geographic region? You start to look at this and what's going on. I tried to throw a little Marvin Gaye thing in there, but I'm not going to sing for you guys because nobody in the room would want that. What we're looking at here is the age-adjusted mortality rates for the top 10 leading causes of death in Detroit, Michigan, the United States in 2014. Whenever we think of Detroit, we think of crime, we think of unintentional injuries as the thing that defines what saps a vibrancy and life from a community. But when you look at this here, the biggest outlier is heart disease, by far. And these are age-adjusted mortality data. And we age-adjust mortality so that you don't end up comparing a population of 90-year-olds and look at a mortality rate to a population of 29-year-olds and say, everybody's dying here and nobody's dying here. Well, it's probably the same rate. It's just you have older individuals and they tend to die more. When you age-adjust mortality in Detroit, it actually goes up for heart disease because you have a lot of young people dying of heart disease. And that's a travesty. So I came here from New York City. I trained at Bellevue Hospital, was indoctrinated in the concept of public health as a mission, at least for my practice in emergency medicine. Not all too common to have ER docs thinking about population and public health. But when I got here, I was really astonished to see 45-year-olds with end-stage heart disease, 40-year-olds on dialysis, all from uncontrolled chronic diseases and things that we, if we put our collective minds together, can probably solve at least a good portion of it. So we see that in Detroit, but we know a couple of things. So heart disease overall is the most common cause of death in this country. We talk about cancer a lot. We can get into why there are certain green states where cancer is more common cause of death versus heart disease. But when we look at the states that are most disproportionately affected by heart disease, there's only two. Rhode Island, and that's so small, who cares about it? No, I'm just kidding. But Rhode Island's really important, obviously, East Coast, powerhouse, East Coast things. But Michigan, right? Michigan is the only other state where heart disease is the most important disproportionate cause of death. And when you look at that, and when you look at what causes racial differences, and we're talking Detroit versus others, we're talking race differences, it's all hypertension. So the most important cause of disparities, differences in outcomes is heart disease. The most important contributor to heart disease is high blood pressure. So it makes a lot of sense that we should really be focusing on this. And it's not just Detroit. I realize this is Mackinac Policy Conference. We have people from all over the state here thinking about this, but there are pockets, if you look at this map, and I thank my colleagues from MDHHS for putting this together, looks at this prevalence. If you look at the dark or the burgundy areas, you can see where there are population centers where hypertension is particularly prevalent and common. And it's not just in Southeast Michigan, but that's the population density and where it's most impactful. These are probably the most important data I may show you. This in the next slide. This is what happens. And the black circles represent African Americans or blacks, and the white boxes represent whites. These are data from ERIC, which is an NHLBI-funded study, longitudinal cohort of more than 5,000 people. These data basically show if you reduce blood pressure at the population level by 1 milliliter of mercury, what you'll prevent in terms of incident coronary heart disease, stroke, and heart failure. 1 millimeter of mercury. Now that's not us, any one of us in a room going from 136 to 135. It's an entire community dropping their blood pressure. That means someone's going to drop 40, someone's going to rise 5, but overall, the effect on the population is this. So yeah, you can drop heart disease incidence or heart failure by 20% in blacks, and it doesn't look that dramatically different. If you drop it by 2 millimeters of mercury, look at that. You can prevent almost 45% of heart failure in blacks just by controlling blood pressure at the population level by 2 millimeters of mercury. This is the kind of thing you see data like this, you don't say why, you say how can we not? How can we not work on this? So when we think about precision health, this is what typically comes up, right? We talk about genetics and looking at the genome and getting the right therapy for an individual patient that will match what drug they're going to be most receptive to and responsive to. Looking at the genome is what we often think about as precision health, the DNA of a human being. What we're really talking about is something different, because we know health outcomes are not just gene-based. There's a lot of things that go into it. There's clinical care, which we always focus on, but the other 3 boxes are the really big, important pieces. So when you look at what contributes to health outcomes, 50% of it is explained by social and economic factors and physical environment. Another 30% of it is explained by health behavior. So 80% of health outcomes is explained by things that has nothing to do with what I do as a doctor. It has to do with what I do after I'm done being a doctor, which is how are you getting home today? How are you getting your medications filled? Do you need money? Now, I'm not saying this because I want you guys to like me, but I go to my shifts as an ER doc at Detroit Receiving Hospital, and I work weekends because, yes, I'm so busy that I can't do things during the week, but I work weekends, and I usually start my weekend shifts with a little stack of 20s in my pocket because my patients need to get medications, and they need to get home. And the health system is not filling in the gap, but I can't let this occur to my population. I have to make sure that they can get the care they need, but I'm just one person. So how do we think of this more broadly? How do we understand what a community needs at an individual level and a population level to really drive outcomes? And you can see here, it's 80%. Has nothing to do with what I'm doing as a doctor. So we often think of it this way. Modifiable risk factors we focus on as healthcare providers, as healthcare involved individuals. We focus on things like sodium and physical inactivity and unhealthy diet. But what affects so much of what's going on are what we call relatively fixed factors. And I would love to see us cross out fixed and relative and just say risk factors that are social, what we're calling social determinants of health nowadays, because maybe they're fixed in some sense, but they're not permanent, right? And as we're going to walk through this, we'll see that there are ways that we can actually figure out what does a community need. So while we talked about precision health being about the DNA of a human being, precision population health is about the DNA of a community. How do we understand what makes up the differences between one area and another? Whenever we talk about Detroit, we talk about Detroit as if it's one single thing. But Detroit has many different subsections and sub-communities, and in those communities, there's a lot of variability. So how do we look at these factors? So I'm going to walk you through a couple of things and then get to the real emphasis of this. But these are data from the Cleveland Clinic, and this is just an example of what other places are doing to look at this. So this is about 110,000 people from the Cleveland Clinic health system who had a lipid measurement, and they looked to try to compare social determinants, taking something called the neighborhood, or what's also known as the area deprivation index, a summative measure of resources in a community that defines sort of overall how much deprivation or how much vibrancy the community has in terms of social resources. And these data basically show where concentrations of high and low depravity exist. And then they overlaid cardiovascular risk. And you can see if you just look at this on a macro level, it seems to be kind of a straight overlap. But then when you add in things that we know produce bad outcomes, such as age, not that age is something we can prevent, right? But age and diabetes and hypertension, all these other things, you see that it's actually not quite the same. They don't overlap, but what you do see are certain areas within a community where addressing the deprivation may have a greater impact. So if we say all of Cleveland needs something, we're probably wrong. If we say certain areas of Cleveland need something, we're definitely right, but how do you identify those areas? And once you get in there, how do you identify what the needs are? So again, this is a single health system looking at people who had a very specific cause to go and interact with the health system, which is to get a lipid measurement. These are similar data from Chicago, which looked at 15,000 people from health clinics to look at the relationship between crime and obesity and blood pressure. And basically what they found is that there is a relationship. The more areas of crime, the worse your blood pressure is, and the more likely you are to be heavy, right, obese. But this is 15,000 people from a community of 900,000 people. So are you getting accurate information if you don't have all the information? We need to be looking at a way to share health data. And so I couldn't believe I found this, but I was saying Phoenix is our project. And I was looking up to say Phoenix the answer. It's really fun to search things on Google, and pulled up this, and this popped up right away. So Bottom Line Records, Phoenix is the answer. And what is Phoenix? Phoenix is a population health outcome and information exchange. And this is a project that we started within Wayne State University, working with the Detroit Medical Center and Henry Ford Health System to start to aggregate data. The idea here is that if you want to lower blood pressure 1 or 2 millimeters of mercury at a population level, how the heck do you ever figure out what the population level blood pressure is? The only way to do that is to aggregate data and start to get a bigger picture of what the blood pressure is to start and what's the blood pressure after you do something to see if you've made a difference. So what we started doing with this is mapping out blood pressures across the city of Detroit by census tract. This is 552,000 encounters over 26 months starting in December 2016. We initially put this map together, and the coloration you see over there shows in orange areas where the mean blood pressure in that community is above the American Heart Association defined cut point for hypertension and hypertension control of 130 millimeters of mercury. So you look at this map, and it's astonishing because virtually the entire city of Detroit is dealing with an epidemic of uncontrolled blood pressure. We've started adding in features, and that's one of the things that we're really here to talk about. We added in features into this map, things that we can look at different counties, we can look at different cities, we can look at different genders, we can look at men. You could see obviously blood pressure is a little bit worse for men. We can look at women, and these are hundreds of thousands of people obviously, and we can look at different age ranges. This is 25 to 64, and as you can see, you go up in the age range, you get higher blood pressures in different areas. But what I think is really interesting is we've started adding in social determinants, and this is something we did just in the last couple of weeks. We added in social determinants so that we can look at the relationship between blood pressure and these social determinants. So we can look at things like systolic blood pressure and age. So if more people are above 65, blood pressure goes up because blood pressure rises over time. We could look at the relationship between blood pressure and unoccupied housing units, right? One of the thoughts that we have behind all of this is that if you have foreclosures and foreclosures lead to worse stress in your life, which then leads to worse blood pressure control, which then leads to a heart attack when you get kicked out of your house, maybe waiving the $3,000 tax lien against the home to prevent $500,000 of lifetime healthcare costs might be a wise decision, right? So that's the way we want to start thinking about this. But beyond that, what we also started doing was looking at individual communities. So we started looking at overlays for populations by their census tract. So this is a community that has a census tract population of 2,122 people and a mean blood pressure of 137. Huge, right? When you look at what this community also has, it has a median household income of $13,000. It has 61% of the population living below the federal poverty line, 35% of the population unemployed, but only 12% uninsured. So 88%, almost 9 out of 10 people in this community have insurance. This is an area where if you were to do something, you could potentially make a viable impact, right? But what's really interesting to me as an ER doc is it's a community of 2,100 people who had 4,500 ER visits over the course of 26 months. So you had more ER visits than people living in that community despite the fact that there's insurance. If we didn't start to pull all this data together, how do we ever know what to target? So if you wanted to do something great in this community, what would you do? You would go ahead and put preventative health services and not wait for these people to develop heart disease, but say, you are going to develop heart disease and we need to help you. So be proactive. But this data right here tells us a lot of information. And really, what's incredible is this population is 29 years old, okay? So 29 years old. So the two things that we know, number one, the prevalence of high blood pressure is lower amongst those who fall into this younger age range, but it's not negligible. It's still almost 18, 20%, depending on men or women and what you look at. But these individuals are most likely to be unaware of their condition. So if we let them be unaware of their condition, what's gonna happen? They're gonna develop heart disease, and they're gonna die of heart disease, and they're gonna die young. And if we let that continue to happen, we don't have a vibrant community. We have a community of people who are dying young from heart disease. And so you look here, this is a 15% chance of developing some cardiovascular event over the 15 to 20 years of follow-up after a patient has elevated blood pressure. So the idea here really is we're looking at not just tomorrow, but tomorrow's tomorrow. If we want to reduce heart disease death, this is not a project. This is a program. This is an all-in, all-partnership approach, because that's the only way we're going to change this. The other thing that's really interesting we can do with this map is look at certain impacts of environmental factors. So this circle sits right over the area where we have our worst blood pressure control on the map, which is also the area where the incinerator is. Now, thank God, I don't know if it's God, but thank somebody that the incinerator is closing because it is, right? And it's closing not because of the organization being magnanimous, but they can no longer make money burning garbage in the city of Detroit. Either way, the incinerator is closing, but what this allows us to do with the map, just by way of another example, we can look at blood pressures in this community because we're longitudinally compiling information and see what is the effect of the incinerator closing on blood pressure, heart disease incidence, heart disease death over time. Essentially what we're trying to do is take a community that's plagued by early vascular aging. And this is a graphic from Lancet a few years ago. And ideally get them to a life course where they can aspire and live long, healthy lives. We have a community, at least in Detroit and a lot of other areas, that sees illness as inevitable, doesn't aspire to wellness, doesn't see the opportunity for this, and we have to change that calibration. Now, an ideal life course may take years for us to get to. We'll take an average life course. That would be great, because that's even far better than we're doing right now. So if we want to get to here, we have to start here, which is taking this information and telling it to the community members to say, we're not saying, what do you think the problem is? We're telling you this is the problem. The data tell us this is the problem, but what's the solution? What do you, as the community member who lives here, need? If we give you this information, how can we change this calculus so that we can actually do something going forward that you both agree with and are willing participants and partners in, but then we also, again, can take the mapping project and track all the outcomes. Now, we are in discussions, like I said, we have 2 health systems involved right now. We're in discussions with the Michigan Health Information Network to expand all of this beyond the state. Essentially, what we really need to do is start to conceptualize shared data and shared information as a way to better inform both where we put our interventions and track the outcomes of those interventions over time. And sharing, again, that information with the community and having conversations with the community, because the community members are the ones who know what we need to do, and they're the ones that are going to help us get there. And this is our community member group that we work with. These are individuals who comprise our Hypertension Community Advisory Board. We've already started doing this work, giving community members this information and having them help guide the initiatives that we're doing, because at the end of the day, they know most what they need at the population level. So I'll leave you with this quote as we're transitioning to the next section here where we have our panel. But at the end of the day, we can derive all this information, but it doesn't do enough to sit in my computer or my desk as an academician. It has to be out there to the population so that we can really drive improvements in health outcomes. So thank you.
Joining Phillip D. Levy on stage is Senior Vice President and Chief Innovation Officer of Michigan Health and Hospital Association, Laura Appel.
So I'm right in your way.
Chief Executive Officer of the Michigan Public Health Institute, Renee Branch Kennedy. Deputy Director of the Detroit Health Department, Tim Lawther. And returning to the stage to moderate the discussion, please welcome David T. Brooks.
All right, thank you again. Phil.
Yes.
Doug, you owe me money because we had an over-under go. After we saw the slides ahead of time,
Yeah.
I figured 2 hours. So I owe you $1 because he did it in less than 2 hours. No, Phil, wonderful job, very insightful. Great use of data, connecting it to both clinical care, but then also common sense, right? I mean, I heard a lot of oohs and ahs even in the audience, especially for an early morning session. That's pretty good. So I think you did a great job kind of framing the issue and then framing the opportunity. I think we've got a number of people up here today who can talk a little bit more about it, but we're all kind of coming from the same common ground. So one of the things we'd love to have, since this is the Mackinac Policy Conference, and I hear there's supposed to always be controversy, is you all have these cards at your tables, and this is to bring forward some questions. I would love you to bring forward or put forward questions that might actually shake things up a little bit, although we'll see if our panelists are able to do that in a second. But pass these forward. Doug, who also broke the rule of wearing a tie when we all pinky swore we wouldn't wear ties today, will be walking around, I think, and collecting these questions. Is that the way it's going to work? So just hold them up at some point if you have one, either from Phil's presentation or obviously from something one of the panelists says over the next half hour or so. Hold them up. We'll collect them real time, bring them up to me. That way I'll have a sense of how many questions there are from the audience. We'll manage our time a little bit that way, and then we'll get on with it. Let me tell you a little bit more about the panelists, if I could, and then we'll get moving here. Renee, as you heard, is the CEO at the Michigan Public Health Institute and has been there since 2014. She's helping to set the Institute's strategic direction in the midst of a little bit of change happening both at the national level with health reform, as well as a lot of transformations that are happening here in Michigan with our public health systems. And she's working to continue to build the infrastructure at MPHI to make sure that they're innovative and keep their programs and projects going. She's a nationally recognized thought leader in health disparities and inequities, cultural competence, and social justice. She came to MPHI from Ingham County Health Department, which was the state's first public health entity. I did not know that. A little trivia for us. Local health department, and also a federally qualified health center where she served as the appointed health officer. She's also an assistant professor at MSU's Human Medicine Program for Public Health. She has her PhD in medical sociology from MSU, a master's in public administration from Western Michigan, and a bachelor's degree in public health nutrition from the University of North Carolina. Tim is the deputy director at the Detroit Health Department, where he oversees the city-level strategies related to health engagement, health improvement planning, human services integration, chronic disease prevention, equity, and the social determinants of health. Tim joined the health department in 2016 as the director of the Healthy Communities Initiative there and was promoted to the deputy role in 2017. In that role, he ensures that the organization takes seriously its role as a public health strategist and a convener to collaboratively implement interventions, both program and policy, that are very data-driven and very community-led, as you'll hear him discuss in a little bit. Prior to Detroit, Tim was actually the Associate Director for Health Department in Jacksonville, Florida, and then somewhere in there he was, between that, he was in Flint as the founding CEO of a federally qualified health center, an FQHC, that was focused on the public housing and homeless population. He has his master's in public health from the University of Michigan and his master's in sociology from Brandeis. And Laura is from the Michigan Health and Hospital Association. She's the Senior Vice President and Chief Innovation Officer, and she has been there since 2000. In her current role, she focuses on healthcare policy, hospital finance, legislation, and governance. At the federal level, she represents Michigan hospitals and health systems at the legislative and regulatory arenas on key issues, including federal healthcare reform and Medicare. She's an expert in auto insurance, which probably has kept you pretty board the last couple months, and legislative policy here in the state, and a proven ability to influence legislation and healthcare policy through her understanding of the issues, her ability to translate some of that, and educating influencers and policymakers. Laura has a bachelor's degree in economics from U of M, and then recently received an MBA certificate in design and innovation from Kendall College in Grand Rapids. So like I said earlier, we have a great panel here. A little bit different viewpoints, I think, than some of us traditional healthcare delivery people. So I think that will be great. Remember the cards, if you would. And I think I'm going to kind of kick it off, if I could, with Renee. And I'm going to ask you to share a little bit about, from Phil's presentation on precision population health and how that connects to kind of your institute's mission and focus and your overall perspective on what you heard today, if we could.
Sure. Thank you, Phil. He tells a complex story in a concise and articulate way. I think where we are now, quite candidly as a nation, is at a point of needing some agitation. We're sort of in a status quo place, but it's very clear that our health is not what it should be. And health is complicated. We used to think, let's just get enough clinics in underserved communities. But we don't really think about why are those communities underserved. This is all about a history of kind of othering particular groups of people and including others. And so we're now trying to push and recognize that what creates health is really about more than what's happening in my body. And quite candidly, what's happening in my body is a representation of much of what's happening in the chaos oftentimes around me. So we know that the United States is not a very healthy nation, despite our wealth, our privilege, our access. My background is maternal child health work, did research in pregnancy and maternal outcomes, particularly looking at the experiences of Black women with white women. But if we took the data around white women in this nation, those women, if they were their own country, would still rank in the lower third internationally. So none of us are doing well. And then when you say Black and women, other women of color are doing 2 to 3 times as badly as white women, we all have a shared problem. So when I think about the data that Phil describes in the Phoenix Project, it's not just about acquiring the data, but it is what is the story that we're going to tell using the data. And so how do we get past the sort of narrative of, well, here's how you stay healthy. You eat your vegetables, no disrespect, Mom. Eat your vegetables, get plenty of exercise, get plenty of rest, because then we got progressive about sleep deprivation. And oh yeah, don't forget to see your doc regularly. Well, we know that that in and of itself is not going to keep us healthy. And so we're beginning to try to push the discourse. The World Health Organization has a wonderful definition of social determinants of health, and it simply is where we live, work, play, and pray. And that's what you see represented in this sort of chaotic slide that I have before you. It's the context of where we either lose our health or where we acquire our health. One last thing I would just submit, that in this nation, the healthy choice is not the easy choice for most people. My last son graduated from college this month. Yay. But a couple of years ago, his sophomore year, he said, you know, Mom, I'm going to start eating more healthy. I'm not doing the fast food anymore. I'm just going to take care of my body and do better. He calls me about 2 weeks later and says, Mom, you're going to have to seriously up my allowance. Like, I can't afford to eat healthy. It was a reality check for him, and it is a reality check. People don't just want to feed their kids supersized French fries. They're thinking about what's going to fill their child so they're not hungry. So the easy choice is not the healthy choice is not the easy choice in this nation. So all of us, regardless of what our field of expertise is, have to think about what is the implication for well-being if you don't think about health. For all of my decisions, both personal and professional, and how do I help create what Robert Wood Johnson calls a culture of health in this nation.
Great job. Thank you, Renee. So Tim, from the public health department's viewpoint, talk a little bit about precision population health. And one of the things that I'm interested in, especially in my new role for Wayne County, is how's this really different than what public health has always done?
Well, that's an excellent question, actually. And just to build a little bit off what Renee said so eloquently, you know, the choices folks make are determined by the choices that they have. And so if we continually focus on the choice, we're missing, in fact, the environment within which those choices are made. And so I think public health, you know, historically was originally focused on communicable disease prevention and sanitation and made tremendous progresses. And of course, you know, increase the the life expectancy by dozens and dozens of years by doing that work. And then it became more about chronic diseases and how can we, you know, to the point of how can we make sure that folks, eat better and move more, basically. Don't smoke, don't drink alcohol, wear your seatbelt, you're going to live a long time. But the reality, of course, is that that's not, in fact, true unless we pay attention to, in fact, the environments that people live in. And so I think the precision public health is, you know, Phil talked a little bit about precision medicine. Precision public health is a very similar concept, but what we focus on is providing the right intervention to the right people at the right time. And each one of those steps is vital in this conversation. You know, providing the right intervention. We'll talk a little bit, I'm sure, as a panel about, you know, evidence-based interventions for community and individual health improvement. There's a lot of work to be done there. You know, there's some evidence that certain programs work better than others in the neighborhood they were studied in. Don't know whether those work in Detroit or Traverse City or Flint. So there's obviously work to be doing there. To the right population, you know, the work that Wayne State and Phil have been leading around trying to get actual individual health information and trying to aggregate that at a locale level is exactly the kind of stuff that we didn't have before in public health. And so that's where this partnership and this idea really comes into play. And then sort of the final point is at the right time, which is what I think at the health department we're most focused on, which is all these data and all this evidence about these programs, and hey, you know, this is a problem, and we gotta come do this to solve your problem, will not work if we're not in developing those and with authentic engagement of the people who are impacted by them. And so, you know, there's a lot of talk, as there has been for years in public health, about you know, engaging the community. And oftentimes what that means is, you know, we give a survey, we, you know, have a little health fair, we hand out some information, those that are basically committed come, and, you know, it's sort of, we go on and nothing changes. It's, you know, the definition of insanity. And I think what we're talking about here is, in fact, actually developing the capacity of community members to understand what these data mean. How do you interpret this information? What is going on in your community, in your neighborhood, that actually makes a difference? Where should I be pointing this? Because there is something. I actually want to go to this next slide if I can. There we go. So one of the things we did in Detroit, actually, we're just in the middle of this process now, is we've conducted a community health assessment. And that health assessment, not only the questions that we asked, but also the process by which we distributed this information and asked these questions, was in fact defined by the community. The steering committee, you know, I sit on the steering committee, everybody else is our community members who sit on the steering committee. And so they helped us define what it is that we're going to be focusing on and what questions we should ask. And you know, you can get the report on the DetroitMI.gov website. Certainly go and get it. I just wanted to demonstrate a couple of things here, which is we asked folks not only, you know, hey, do you have high blood pressure? Have you had cancer? Do you have heart disease? But also, sort of, what are the assets in your community? What are the strengths of the neighborhoods that you are living in? And we got that information, both for the city as a whole, as well as each district. We divide, you can argue whether this is logical or not, but we divided Detroit into the 7 city council districts, just to sort of get a smaller area of focus. And so we compare what that district said to those questions to the rest of the city of Detroit. And it's not, the vital component of this is not the comparison with the city, but is in fact, what do people find important? And what are the strengths and assets we can build off? And so I'm sure we'll talk a little bit more about how, in fact, we connect the data with the actual community member to be successful, which is very different in public health.
Great, thank you, Tim. So Laura, give you the chance as well to kind of comment from the hospital and the health system's viewpoint. Kind of what value can this broader thinking bring?
Well, I want to start with, I really appreciate Dr. Phil and Wayne State for making sure that healthcare was somewhere on the agenda of the Mackinac Policy Conference.
Yeah.
The map that you showed and the census tract that you highlighted that demonstrated that the problem with hypertension was so prevalent among young people. You know, a lot of this conference is dedicated to talking about talent and the workforce that we need. And if we have a workforce that at the age of 30 is already suffering from pretty serious hypertension, we're never going to accomplish what we need in terms of making this a vibrant economic community. And so I think that really highlights how important health is to what's going on in the region that's covered by the Detroit Regional Chamber. And yet, you know, our time slot is 7:45 on Thursday. So I think it's a credit to all of you and a credit to Wayne State for making this really a focus, but we have to elevate this. The next thing I want to say is, you know, dealing with social determinants, I had a chance to talk to Jean Meyer, who's the Ascension leader here in Michigan, and you would be familiar with them, Providence and St. John hospitals. And she remarked that, you know, one of the ways that we've been dealing with social determinants in the upstream of environment is hospitals have been supporting school-based health centers for years. We don't really have a lot of public money that goes into school-based health centers, even though we know that kids who have access to healthcare are much more likely to remain in school and do better in learning. And yet there's no real investment there from the public dollars, other than we finally figured out how to be able to bill Medicaid and other insurance. So I guess one of the things that I would say is, when we have a problem with something like hypertension at such a young age, how is this built into early education and education at all. And we talked about, Renee talked about that this is something that, or maybe it was Tim, that we are not aspiring to good health and that needs to change. Well, how do you change? I mean, you get people young and you do it as part of the education system. So I think the hospital community is already firmly engaged in trying to make change where they see their opportunity. But what I've always said to folks is, the closer it is to what fits inside the four walls of hospitals, the more responsibility I think the members of the Michigan Health and Hospital Association feel like they have. You know, stuff that's happening in the operating room, 100%. Things that deal with, like you said, you keep $20 bills, you know, stuff that's happening with our patients as they're exiting the hospitals, 80%. But when it comes to housing, maybe we're like 20 or 30% in that. When it comes to food, again, maybe 20 or 30%. But the farther away it gets, I mean, we're always going to be a partner, but we cannot do all of it. I mean, we're better at the clinical stuff. We need to be a partner in all of it. And I would also comment on the map. The map is orange. Yes, there are some gradations of it, but the map is orange. Everyone has hypertension.
Yeah.
I have hypertension. Raise your hand if you're over 50 and not taking lisinopril. But there are not very many hands. So I think the thing is that we either are genetically predisposed to having hypertension, in which case we have to face up to the fact that you're going to get to a certain age and you have to deal with it, which means that you have to know that that's going to happen and you have to see your physician to deal with it and you have to fill that prescription so you have 365 days worth of pills. And that only happens because we're all educated about how to do that. You know, we're all educated to brush our teeth every day. That didn't happen because you just woke up one day and knew that. You were educated about it. And I think that those are some of the things that are missing. So I think that, you know, the hospitals are already firmly committed to being partners. This data is going to help us be better partners. We've just already started the conversation with MPHI about how we broaden this work on social determinants. But I think that it's like Dr. Levy said, we are all working at this. The organization of doing it, I think, needs to be more solid, not because people aren't doing enough, but because we're just not doing enough of it in an organized fashion. And we had Jeffrey Canada here a couple years ago, and he did a great job of explaining how you do this really well with a super genius and some billionaire partners. And David Erickson, who's a PhD out at the San Francisco Fed, you know, he's writing about this right now, saying, you know, we have to figure out how to scale this without having those components. And that is, you know, using the resources we do in the smartest ways possible. And I think this kind of stuff will really help them.
So let me change it up a little bit then from our plan, because I've got a couple questions already handed to me, and I want to connect it, Laura, to some of your comments about the hospital systems. And this first question that actually came up is, I think it'll be important to talk about from the panel's view, each of your perspectives. How can we shift the business models in healthcare to focus on the social determinants of health? So I think that implies it's shifting from something which basically I think is predominantly toward clinical care and institutional care historically, is at least where the perception is the large part of the dollars go. And related to it is, how do we get Medicaid to start paying for things, and that's specified out here. So another question came forward talking a little bit about where the health plans are. So I think you can kind of look at it as with the financing vehicles of healthcare. How do we get the financing vehicles for healthcare to start paying for things like transportation for pregnant moms to get to a mentoring program, or healthy food, or other preventive health interactions or interventions? So talk a little bit about that.
I just want to make a really quick comment about the first part, and I know Renee is going to have all kinds of comments about the maternal support. So from the business community, you know, business community really wants to focus on measures. And I want to tell you that, for example, the Henry Ford Health System, they did their own research about readmissions. And this is when people return to the hospital after they've had a service and they go back within 30 days or so. And what Henry Ford found was that people who are elderly, over 65, have a much higher propensity to return if there is no one living in their home with them. Now,
The socialization issue.
well, there's nobody there to help.
Right.
Have you ever gone home after surgery alone? I hope not. It's impossible. So if you go home and you're alone and you're trying to remember to take your prescriptions or your wound needs care or whatever, doing that by yourself is virtually impossible. So the measure is whether or not you're readmitted. But what is the health system supposed to do about whether or not you have someone who lives with you? That's pretty hard for the health system to manage. And yet that's the measure. So the measure is this output of whether or not you came back. But the real outcome we need is support for that person in their home. And if you don't have a spouse or a family member, that's not a medical thing. That's not a clinical thing. That's a social thing. And so I think for the business community, you need to be thinking to yourself, what exactly am I measuring? How much is this helping what's really going on here? And think twice about what the measure is and how you're really focused on what you're measuring and what the real underlying need is for that patient. Because that patient doesn't need to know whether or not they got readmitted. That person needs help at home. And we're not doing a great job of measuring that outcome.
So I think you teed it up well. Renee, why don't we give you a chance to respond to that?
I agree completely with Laura. The interesting thing is we are in an era of leading change. If we had been born 50 years ago, maybe our jobs would have been easier. But thinking about how do we do things differently? Now, our funding models don't really align with where the needs are right now. So we have health systems that have the perception of being so hugely funded, right? And from those of us outside of health systems, we say, oh, they got all the money. And those in public health say, you know, we're just begging broke out here. And really, there's a limited pool for all of us. But really thinking about how do we partner and align. I will say that Michigan's Medicaid is a little bit more progressive than what I've seen in some states. They are funding community health workers. They have right now a health equity project where they're requiring health plans to fund some of these social context resources that have been described in the question. But beginning to, I think, as Tim said, abrogate power a little bit. Let the communities lead and drive our agenda. When we did our health assessment, we sort of, even as a health department, said we think obesity is the thing, and our health system partners said, yeah, childhood obesity is the thing. And we talked to communities and they said, yeah, about that, we're concerned about safety, because if they don't live, then they're not gonna get to be overweight. And we struggled. Our health system partners were like, we need to lead the table on that. We can't do anything about that. But how do we bring our own expertise to driving solution and using our power? Because if you're in this room, you have power and you are a person of privilege. You have access, you have education, you have relationships. How do we then, even if we're not going to do it directly as a health system member, how do we use our power to leverage resources, to leverage advocacy for those in other fields, and certainly with community, not just for community?
And you know, if I could just build on that a little bit, I mean, this idea of community health workers that Renee talked about is in fact, sounds very simple, but is in fact vital. We do have the power to advocate for insurance providers to pay for community health workers to go into homes and help people after they get out of the hospital. That is a relatively simple policy change that other folks have enacted, and we in Michigan have not yet done so. We could make that change tomorrow if we wanted to. So there are things that can be done that we know work that relate to, here's what the data show, and here's why we need to be connected to actual people in a community impacted by this, and let's bring those two things together with a very simple policy to fund that work. So there are things that can be done.
Great.
If I could just jump in before we do that, because we're
Looks like
talking a
you're
lot
gonna.
about patients, but I want to kind of pull us back to populations, because the readmitted individual is one person, but a population that has risk for hypertension with adverse consequences is a whole different ballgame. So I think all of this thinking has to be informed by the information. So before you discharge a patient, are you going home alone? When you reach out to a community and you look at what the resources are, and we see you're an outlier and have more people who are going to die young from a problem, we have to be proactive and get into that community and get the information out there. So I think it's interesting, because you have social determinants at the individual patient level, and then you have social determinants at the population level, and they're intertwined. And until we start to really appreciate sort of that broader picture, it's going to be challenging to move either needle. And I think this is tough from a hospital perspective because the goal of population health and hypertension risk reduction is, no offense, to not go to the hospital, because we don't want to get people admitted for heart failure and strokes. Unfortunately, like Dan Gilbert not even being here because he had a stroke, right? You know, we don't want people to develop that because we have prevented the upstream risk factors, but we're never going to accomplish prevention of the upstream risk factors if we don't take care of the social determinants that feed into all of this. So it's just a complicated sort of way to conceptualize this,
Yeah.
but you have to have the information in order to be able to do this.
So we've got to, I mean, I think it's a good point there that we've got to look both micro, patient by patient, clinical encounter by clinical encounter, as well as at the macro level population side, which is one of the questions that actually came up, which was one of the ones I was going to bring up later on as well, which is how do we now take this information and this data that you've already specified kind of in the initial work is real specific to discharges within the city of Detroit, and start looking at it broader. That's part of the involvement we've had from Wayne County, but also even at least southeastern Michigan, maybe eventually the state of Michigan. So Phil, maybe talk a little bit about that, because I think it'll be important. A lot of people in this room are not only specifically focused on the city of Detroit.
No.
So how do we broaden that population viewpoint?
100%. So the reason to start with this conversation is obviously because this is the most impactful thing affecting outcomes in our state, but it's the most impactful thing in Detroit for sure. It may not be the most impactful thing in Grand Rapids or in Lansing or wherever you're considering. At the end of the day, to some of Laura's point too, we have to look at this as a shared responsibility from a population level. So oftentimes health systems, even though we have the Michigan Health Information Network, look at data as proprietary to their system for the patients they care for. And an MRI at Henry Ford is not good for a patient who then goes to DMC and gets their surgery based on an MRI from a hospital perspective. We have to sort of break all that down and say, how do we share collective information so that we can work together to figure out problems? So what I ultimately envision with this whole Phoenix thing is that we work with the Michigan Health Information Network. We start to aggregate data. Each community or region can use the mapping infrastructure for whatever purpose they want. It doesn't have to be hypertension related. We can look at things like hemoglobin A1Cs or glucose or forced expiratory stuff for asthma, whatever we want to look at as an endpoint, but it gets beyond exactly to what you're saying, Laura, which is it's not about readmissions. The target thing that we want to do from a population level is this. It's reduced asthma revisits. It's better functionality with asthma so that kids can attend school and they can grow and be and do whatever they want because they're not hindered by health effects that are caused by population level things like pollution. But I guess to your point, David, it has to be an agreement that we share data for the public good. So if we hold on to data as proprietary, HIPAA's done a lot of wonderful things to protect people's information, but it's been a barrier to this concept that we can share health information for the greater good. And I think stepping away from this protection of HIPAA and saying, how do we work within it to be able to all look at the problem and have equal footing on information is the key.
I think the other thing that I would say is that we have been really focused on healthcare, measuring healthcare costs, all of these things. I would ask, and don't worry, we have enough patients. So we could cut down on a bunch of patients and still have enough because people are getting sick at way too fast of a rate. And so what I would say is the real thing to focus on for the people at this conference is health and preserving the health that you have. Because when you lose it, it's really hard to get it back. And in a lot of ways, there are miracles. People that work in the ED, like Dr. Phil, do miracles. But over time, if you lose your health to chronic illness like diabetes and you lose your blood vessels, you can't get it back. And that's what we need. We need people who are healthy enough to live, work, and play. And we are losing that. And that is the challenge. And this data helps us see where the loss is greatest and where we need to make the investment. And it's got to be a shared investment, and it's got to start early with children and education about how you got your health and how you have to keep it. And that's not something we can do at the clinical level. If we're getting to the clinical level, we're probably too late.
So I would argue we're in a both-and space. It is rare to find a physician who is articulate as Dr. Phil Levy around this work. The lines between our areas is blurring. The line is blurring. So as a medical sociologist and a public health professional, I need to have some understanding of the context of the clinical environment so that when I build the narrative, right, when I have the conversation with my peers, we can understand what their self-interest is, what their priorities are, and what ours are. If we're continuing to do our work the same way we've always done it, as Tim said, that is the definition of insanity. We are going to continue to see babies dying early, moms dying early in childbirth. We have to understand that housing policy is health policy. That it's not about getting someone a job, but is it a living wage? We talk about ALICE, the United Way talks about access limited income, I forgot what
Poverty rate.
yes, restraint. So constrained. It's not just about getting a job. It is the nature of the job. So employment and policy is health policy. And health care, as all of our slides have demonstrated, is a part of that continuum, but we are all responsible. We're all responsible thinking about how we do health, health care, public health, population health differently in this nation.
So on my not so subtle timer, you guys can't see that, is telling me we've only got a couple seconds here to wrap up. So first of all, I'd like to thank Dr. Phil, as we will now call him from
Dr.
this
Phil,
point
all right.
forward.
The real doctor.
I'll give you my mental health copay later to psychoanalyze me. For the keynote presentation and the great use of the data. Our panelists, Wayne State University for sponsoring this, and actually working with Phil and all the research side, doing some really breakthrough research, particularly in the urban community of Detroit so far. The broad challenge I just heard from Renee for all of us, and two specific challenges. One, let's make sure this type of conversation moves out of the back room into the theater at some point at this meeting, so that we can align policymakers and CEOs and others, C-suite people and others, toward this broad conversation about health, not just health care, but health overall. And I heard from the infamous Dr. Phil. I heard that we need to do more about getting access to all the information, not just kind of what we started with the pilot through the Phoenix Project, the pilot sites, but actually all the healthcare data, de-identified, of course, and bring that forward, because I think your slides and your ability to influence policymakers and us in the communities will be even stronger if we have even more information. So with that, unless there's any parting shots from anyone else in the audience, I think our time here is up. If I'm getting the head shake, yes? So we need to wander on to the theater and the next session. So again, a round of applause for our presenters and panelists. And thank you again all for joining us early for the conversation.